golf and all that sort of thing. It's one of the richer parts of England, so a lot of people retire by the sea. So we have a very well elderly population. Of course, they're getting older, but they have these problems, but they're still living a good life. They still drive and things. So with a third choir, there's an introducer, there's a needle that there's a special thing that allows you to introduce a needle under the skin. But if you don't have it, you can still do it with a normal needle. You just need to bury your sutures. So everywhere you put the needle, you need to make a small incision so that the suture can go under the skin. And you just go around the sphincters and put this circular, there's a special needle for it, but you can do it with any non-absorbable suture, preferably something that's not braided, like proline or nylon. And so in somebody with a prolapse that's coming out and you can't do anything about it, under local anesthetic you can do this. Push the prolapse back in and then put the needle around and tie it under, ideally you tie it under the skin. Then there's the Delong's procedure, which we talked about. So when a prolapse comes out, an external prolapse, if it is less than 5 centimeters or less, you can repair it through the perineum successfully. If it is more than 5 centimeters, ideally you should do an abdominal repair, because if you do perineal, when it's more than 5 centimeters, it means the sigmoid is inside the prolapse as well. If you do it perineally, it will fail. Usually within 6 months to 12 months, it will come out. Unless, again, the patient is bedbound. So we have nursing home patients, people who largely don't move around. You can still do this for them and they'll be fine. But anybody who is walking around, who is still active, if you do a perineal repair for a more than 5 centimeter prolapse, it's likely to fail. So the first step is to inject a mixture of local anesthetic and adrenaline. The adrenaline helps to stop bleeding. It can be a very bloody procedure, particularly if you get into the hemorrhoidal vessels rather than go above them. So you inject submucosally to lift the mucosa off. You use diathermy. Some surgeons just use a knife. I've done it with a knife as well. It's quicker to do it with a knife. Once you raise the mucosa with the local anesthetic, you can just strip off the mucosa with a knife, and then you can deal with any bleeding afterwards. But you can use diathermy. It's neater, but it takes longer. And then you strip. It's the muscle of the rectum. This is the mucosa. And when you finish stripping the mucosa, you need to chase the mucosa into the tunnel of the prolapse. And then when you finish, the way you take in a big bite of the muscle from above the dentate line into the apex of the prolapse, to pleat a skirt, for example. So that's what you do with the prolapse. By the time you put 8 sutures around, you end up with this result. So you put all the sutures, and then when you finish, you tie the suture, and then it bunches it up and it goes back inside. So if it's 5 centimeters, this works. You don't need to close the mucosa end to end. Mucosa heals within 48 hours. We would usually give them some antibiotics post-op. I know everything we do in Nigeria, we'll have to give antibiotics anyway because of the infection, but this is one of the procedures we give post-op antibiotics. So we talked about Altmaier, which is still a valid procedure in this environment because doing a rectopexy is very expensive, right? There's laparoscopic, there's all sorts of things. So if you're in Nigeria and somebody has a prolapse more than 5 centimeters, if you are skilled at doing an Altmaier, then do an Altmaier. In fact, the history, Altmaier was discovered by accident. Somebody was doing a Delong's, and they went through the muscle and cut it. So the only way they could rescue it was to resect the sigmoid. So it was this procedure. You can see the beginning of it is like a Delong's. So you were going through, but in an Altmaier, you do an intentional full thickness dissection. And so basically, you can see here, so you go through the rectum, and underneath it, you'll see the sigmoid coming down. And then you take the whole thing, you resect the sigmoid, divide the blood vessels. Here you can see they tied up the blood vessel. And you essentially do a sigmoid to anus anastomosis. And that deals with it's very effective. But if you don't do this, because to many colorectal surgeons, you look at this and you think this is madness. Because when you do an Altmaier, you don't defunction. When you do a low anterior resection for rectal cancer, you would give them a temporary ileostomy. But when you do this procedure, you don't give them an ileostomy. So it seems counterintuitive to many of us, because, you know, if they leak and you don't recognize it, they could die, because you then have an abdomen full of feces. But in good hands, in well-trained hands, if you've done bowel prep, you watch the patient carefully for the first few days, I still think it's a valid procedure. We don't do it in the UK because in the time it takes me to do this, I could do a rectopexy, which is more fun. It's less bloody. So I wouldn't do it. But if I was here, I think this is a valid thing to have in your toolkit. So I'll talk about STAR briefly, what it is, but basically contraindications. So if it's asymptomatic, if somebody's got a prolapse, if it doesn't bother them, I have patients even in the UK that have an externalizing prolapse. It comes out every now and again, they push it back in, but they don't want an operation. So we should never, in benign conditions, we should never recommend surgery to a patient. And if a patient comes to you and says, do you think I should have my hemorrhoids fixed? And I'll say, what do you think? You know, any patient who's asking you, do you think I should have surgery?